Oh, my pleasure. Thanks for having me. Sorry about the hookup problem. Um, Thanks, Jerry. I will see you in November for the next meeting that you're having. And thank you, Patrice, for putting on this meeting. I had the meeting last year, and she was just out of her mind the entire time. I've never seen somebody work like that. So I very much appreciate her effort, and I very much appreciate her including me. My better half will actually be there, Dr. Ravindra, this evening, speaking tomorrow. And he always does a better job than I do. So basically, you're going to be hearing a lot of people talk about syringomyelia. Mine is probably just an introductory discussion to leave for everybody else. So a primary syrinx occurs in about 1.4 cases in every 100,000 people, and unfortunately has an orphan designation as far as research and treatment based upon this incidence. A number of definitions I think that you need to know. Hydromyelia just means the central canal of the spinal cord is dilated. The central canal is lined by ependymal lining, whereas a syrinx is adjacent to that. It can include the central canal, but it's not lined by ependyma. If you have extension of the syrinx superiorly, it can extend to the medulla, syringobulbia, farther up to the pons, syringopontia, to the midbrain, syringomesencephaly, and then syringocephalus to the cerebrum. All these latter are very, very rare. So if this is your spinal cord, basically cutting through the body and looking inside, this is the tissue of the spinal cord. This is the central canal. So this would be hydromyelia. So a buildup of fluid within the central canal, once again lined by ependyma. Where syringomyelia is a cavitary lesion within the parenchyma of the cord, adjacent to the central canal, may not involve the central canal, but also can. But it is not entirely lined by ependymal lining. And so that's a primary difference between the two. And then as far as extension, syringobulbia, extending up into the medulla, syringopontia, extending to the pons, syringomesencephaly up to the midbrain, and then basically extension into the brain, but that's something I don't believe that I've seen to date. So a primary syrinx is an acquired syrinx. It can be acquired secondary to trauma, atraumatic events, or tumors. You can have direct trauma to the cord, blunt trauma, penetrating injury. You can have result secondary to surgery, which is a traumatic event to the cord, especially for spinal cord tumors, things where you have to cut into the cord to get into the central canal. You can have a bleed into the cord, or you can actually have a stroke with a secondary bleed. And all of these are considered traumatic in nature. Atraumatic, ischemia, where you're not getting enough blood supply to the cord and you have secondary swelling of the cord. A tumor involving the cord. Stenosis spondylosis, so basically spine disease with external compression of the cord can result in a syrinx. And lastly, tumors. There are intrinsic tumors, tumors within the tissue of the spinal cord. Extrinsic tumors, which are usually tumors on the outside that are pushing on the tumor, creating a mass effect of sorts. Cyst development, either outside of the cord or inside of the cord, and a bleed into the cord associated with a tumor. All of those things can be secondarily related to inflammatory response or scarring response, a normal response when you have any kind of injury to anywhere in the body. You can have immune response, which leads to aggressive inflammation. You can have infectious response for an infection of the cord, usually secondary to surgery, but it can be from a meningitis or some other acquired infection. You can also have inflammation secondary to arachnoiditis, something we can see after we've operated on the spine where you have inflammation of the arachnoid covering, which is the in-between covering. The dura is the outer tough covering, the pia is almost like a spray paint on the cord, and the arachnoid is this kind of spiderweb looking gap in between these two. So there's an overplay not only of the initial event that triggers something resulting in the syrinx, but also the secondary inflammation to that or other events. So do all of these etiologies result in compromise of the subarachnoid space? A post-traumatic injury is usually a progressive neurologic defect above the injury that begins months to years after initial trauma. The actual incidence is problematic in that it rarely leads to paraplegia, but even a 1 to 4% incidence is problematic. It's probably occurring much more often than initial publications suggest, and that's just because with better imaging and more frequent imaging, we're seeing a higher incidence of post-traumatic syrinx. Spine disease, stenosis, spondylosis, disc disease, all result in external compression of the cord, which can result in the syrinx. And I'll get into the mechanism in a moment. Post-inflammatory, there's a delayed reaction to either infectious or chemical inflammation that can create scarring. As we just talked about recently, scarring can additionally be problematic. Tumors, extrinsic, intrinsic, any of this disease leads to compression of the spine CSF pathways. When we see fluid associated with the tumor, it's usually believed that the fluid is from the tumor and not necessarily from disruption of normal CSF flow of the central canal. So if we see a tumor syrinx, if you will, the belief is usually that that's related to tumor fluid primarily. So here's a cut through the cord. All of these little indentations or spaces are ways that blood flow get into the cord. And these are called Verco-Raban spaces. So on this cut, this is the subarachnoid space. Once again, this is the dura, and this is the arachnoid. So you have normal flow of cerebral spinal fluid around the blood vessels within these small pathways going into the cord. So that's the dura, subarachnoid space, artery. So, and you're going to be hearing much more about this, basically a theory of Dr. Heiss that makes a great deal of sense, and that's why I'm bringing it up. It's believed that the brain expands during systole, the beating of a heart, and it creates a pressure wave which heads down the cerebrospinal fluid spaces, if you will, but this is dissipated like speed bumps throughout that path. Now, if you obstruct that pathway, and once again, these are the Verco-Raban spaces and those pathways, you create an obstruction, you're blocking or tamponading that dissipating response to beating of the heart, if you will. And that can result in secondary syrinx formation. It basically stops this normal flow, and then the only potential pathway is into the Verco-Raban spaces, which then become dilated and can result in a syrinx. So communicating versus non-communicating, and Miller had done a good job of defining this, but basically if this is the fourth ventricle, if I'm looking from the side, this is the pons and brainstem, this is the cerebellum. If there's communication between the fourth ventricle and the central canalar syrinx, that's considered to be communicating. If there's a disruption where there is an area where there isn't a syrinx or isn't an enlarged central canal, that's considered to be non-communicating. Extracanalicular means that there are cavitations that arise in the parenchyma of the spinal cord and don't have any communication at all without the central cord. So I think this is a basic but a pretty understandable concept about whether a syrinx or a cavitation is communicating or not communicating. So why do we worry? This is the CSF pathways, this is the cord. So you're starting with the buildup of something within the cord, and you're creating pressure. That can be a bleed, that can be tumor fluid, that can be separate cavities within a syrinx formation, which make things even more difficult. You can have the formation of secondary syrinxes. And what this does, it leads to expansion of the cord, or internal expansion in this scenario. So you start out with this central mass, you get a secondary bleed in the cord, just as an example. you get expansion of the cord. This expansion of the cord disrupts the CSF pathways, and that can result in a secondary syrinx. Once again, partially within the central canal, some of it outside of the canal, and this is forcing this fluid to the Virchow-Robin spaces and creating enlargement of the syrinx. And this can create compromise. Trauma, about 1 to 7% of patients with spinal cord injury can develop clinically symptomatic syrinxes. The numbers are likely increasing, once again, secondary our technology of imaging, and the follow-up is longer. So we're spending more time looking at this. When we look at trauma, we're looking at obstruction to flow. So looking from the side, this is a traumatic fracture of the vertebral body. You see blockage of the CSF pathway. This can be the result of scarring, hemorrhage, arachnoid adhesions, penetrating injury, kyphotic deformities, arachnoid scarring, just a myriad of things result from trauma that result in this obstruction and secondary syrinx formation inferior. The timing, it can be basically as early as a hematoma cavity resolves. So you have a bleed into the cord and that resolves and remains as a syrinx. The diagnosis can be anywhere from 9 to 15 years following the injury, and the range being from 1 month to 45 years post-injury. So with traumatic injury, continued follow-up and imaging studies need to be obtained. Having 2 years of studies and saying you're not seeing anything probably are not good enough, especially if you have evidence of a prior cavitation, bleed, or even enlargement of the central canal. Thoracic trauma tends to be more problematic than cervical trauma, especially with resulting in the formation of a syrinx. More likely to occur in older patients, more likely to occur if there's a complete injury, complete loss of function in the spinal cord, or complete separation of the cord. So an MRI with regard to tumors can give you a lot of information about the tumor. The size, the location, the length, is it getting bigger? Is it associated with a cyst? Of the types of tumors we deal with, astrocytomas tend not to have a well-defined border and can have large satellite cysts within the cord, either remote or proximal to where the tumor is. Intratumoral hemorrhage or bleeding into a tumor, usually caused by an ependymoma. Ependymomas tend to have a very good plane, so surgically are more accessible and likely to be removed, but tend to be associated with hemorrhage more often. Hemangioblastomas have a mural nodule, so it'll be an external nodule that can be associated with the syrinx. And this can also be problematic because you can have a great deal of swelling surrounding these types of tumors. So tumor-related syrinx, the outcomes can be guarded. And if you have a syrinx associated with a tumor, this just makes the existence of the tumor and the need for surgery more problematic. If somebody comes in and presents with an injury to the cord, they have a worse outcome. Somebody with metastatic disease, the presence or absence of a syrinx rarely live beyond 12 months. Pain control is a significant challenge and something that most of our efforts are directed at. In managing these patients, a critical care specialist who's a pharmacist specifically needs to be part of the management protocol, and you need a team approach, if you will. Different types of providers, different specialization, all of which need to be involved to come up with really the best management and outcome of these patients. Spine disease. Spine disease is basically related specifically to abnormalities of the spine itself. Once again, compression leads to movement into the cord and secondary formation of a syrinx. Spondylosis is just degeneration of the spine. Now, as I said, thoracic abnormalities create a syrinx more often than cervical. So syringomyelia is rarely associated with the cervical spondylosis. Tends to be secondary to a localized adhesive arachnosis at the spondylosis site. So where you have the spondylosis, you can have inflammation of the arachnoid, and it's that inflammatory response in addition to the compression that are likely the problem. Syrinx size has a lot to do with the size of the spondylosis. The greater the compression, the larger your syrinx is going to be. And usually the syrinx develop distal to the spondylosis, but they can occur proximally. So Heiss, who will be talking to you and really came up with this theory I talked about forcing fluid through the Virchow-Robin spaces, really came up with this hypothesis Brierly looked at movement of CSF tracers from the subarachnoid space into the spinal cord, which essentially supported that this works, that this makes a great deal of sense. When we treat patients with a primary syrinx, symptomatic problems being present or not, surgical correction is really the primary approach. Once you do a surgical correction, we tend not to want to do a direct approach to the syrinx itself. So a direct surgery, putting a catheter in the syrinx, or opening up the syrinx wall is something we historically don't do. The majority of patients have asymptomatic syrinxes. Really, we follow electively because they will either stay the same size or spontaneously resolve. And I think surgery is a little too aggressive in those patients. In general, descriptions of a syrinx. This is a patient that provided an image of their conceptualization of syringomyelia, headache pain associated with the syrinx, basically torture for patients over the long term. So what are the responsibilities on your part as a patient? Pain is the most commonly reported symptom. Does it mean something? It's usually localized at the level of the syrinx or diffusely below the syrinx. Tends to be neuropathic. It may increase with changes in sitting up, lying down, coughing or sneezing. Tissue tenderness at the zone of injury can feel identical to a bruise, so there's local pain. An ascending sensory level may or may not be noticed. That's why neurologic exams on our part are critical. Losing the ability to void, erection, bowel function are all obviously problematic, and you need to see your physician immediately for further workup should that occur. Us as physicians, our responsibility, is there increased numbness, weakness? Is the weakness older? Is this something new? Is there a sensory dissociation? Is there a selective loss of pain and temperature while you have preservation of touch and pressure, which is a sign that something is progressively going wrong? Is there changes in the tone and spasticity and your ability to move and your motor function? Are there autonomic changes? Are you progressively losing your reflexes? These are all things we need to figure out to make sure that you're being properly followed. Personally, MRI scans, there tends to be a lack of correlation between symptoms and cavity size. Small cavities can create significant problems. Big cavities may not. It's all very specific to the patient, and that needs to be understood. The cavity is usually found at the site of injury, obstruction, colon fracture, angulation. So this concept of external pressure, internal injury, the level it occurs at is significant. If you can't get an MRI for any reason, or it's difficult to read an MRI, CT myelography is the best way for us to follow, because we need to get the information on whether there's cord tethering, dural adhesions, or an obstruction. EMG is also helpful in the way that we follow you. So these are all modalities that I personally utilize to follow my patients. Treatment, progressive symptoms and or disability usually will require surgery for all the reasons we discussed, whether it's inflammatory, tumor, spine disease, or trauma. Small cysts in asymptomatic or minimally symptomatic patients don't really need initial surgery. I tend to follow those. The problem is conservative management in people with a progressive deficit may result in some spontaneous regression of the cyst in some patients, but there can also be a pretty significant chance of the risk of neurologic worsening. So there's a lot of trepidation in how aggressive we are in patients with a syrinx, large or small, whether we should operate based upon symptomatology, given that we try not to operate, and we may be lucky, but we tend not to be gamblers. So current approaches, we're just trying to reestablish normal CSF flow, whether it's from inflammation and blockage, external compression. All of these things are the approach in general. Our standard is to reestablish that normal CSF flow. So we need to address the primary problem. If it's spinal, we do that. If it's tumor, remove the tumor. We need to widen the CSF space, placement of duroplasty. When we do decompression of Chiari's, sometimes we need to shunt, putting a catheter in a syrinx cavity and then placing that under the skin and draining it into the abdomen, into the cavity around the intestines. Any of these things can result in a secondary syrinx just because you're treating trauma. And as we've noted, trauma to the cord can result in problems. Management, do you shunt the syrinx cavity? If you do so, how? Does it go to the peritoneum? Does it go to the lung? Shunts may require replacement. If you have a shunt in place and things are fine and things are getting worried, it may be that the shunt is plugged, like a toilet would be plugged. Shunt failure with cavity recurrence and shunt-related complications are very high in some groups of patients. We have some patients needing a number of revisions and some that never need a revision. It's very individual and it's very hard to predict who is who. For those symptomatic patients who undergo a surgical procedure, you've got to have good results with regard to your radicular symptoms, but less encouraging results for autonomic symptoms or spasticity. So we have a better chance of reducing pain than we do the autonomic symptoms you're presenting with and the spasticity. Cessation of symptoms or improvement occurs in nearly 90% of the patients that do undergo surgery where the primary problem is addressed. Innovations, you need to be aware of any potential innovations because anything new is very important. Consideration of stem cells, autologous bone marrow-derived mesenchymal stem cells being injected into syrinxes is an appropriate consideration. It may not even be that they need to be injected. Intravenous administration of these type of stem cells, as Dr. Cropper can also talk about, based upon the study in stroke patients, shows that the cell-to-cell communication occurs without directly putting mesenchymal cells into the cord. So just intravenous administration of cells may be enough. Follow-up and treatment, serial neurologic exams need to be followed closely, and we need to pay close attention to the complaints. Problematic headaches, spasticity, weakness, changes in sensation, all need to be reported to us and need to be acted upon by us. Any changes, ambulation, propulsion in a wheelchair, these all suggest progression and these suggest something we need to work on. Cervical syrinxes are more worrisome because pulmonary function needs to be assessed. So you also need to see a pulmonologist so we can frequently follow vital capacity. This may change, you may not be aware of it. Interdisciplinary evaluations, rehab teams and associated with neurosurgery, neurology, orthopedics, pain management, really needs to be a team approach to patients with these problems. We need to mitigate the increasing risks of complications such as pressure ulcers, decline in mobility, and falls. So if there is an injury, progressive, had it operate, and it stops, but it's not improving, we need to continue to follow these patients to make sure they don't have secondary compromise to the level they are at now. These are all complications related to a syrinx. These are all things I've discussed, but extreme large number of problems can be associated with a syrinx. All things that need to be reported initially and followed in their absence to see if they are something to develop over the course of time. So neurosurgical consultation when surgery is being considered is important. Electrodiagnostics, I think, are helpful in trying to figure out how we can help, and especially for a concomitant radiculopathy, because we can make that better. Nursing and social work help, rehab specialists, PT and OT, pain specialists, urology, psychology, psychiatry, cognitive management, all are essential to the continued management of patients with this problem. Lastly, we need to address the emotional and physical challenges, not only of the disability, not only of lack or progressive lack of function, but for pain and the psychological overtones of chronic significant pain. We need to discuss how new deficits are treatable and how good outcomes can actually be, especially with regard to pain in the majority of patients. We also need to address the need for aggressive rehabilitation, not only to basically improve their prognosis, but to improve progressive motor function and decrease the presence of spasticity. So I've tried to give a quick summation of primary syrinx, how they form, the difference between the central canal expansion and a syrinx itself, the etiologies or causes of primary syrinx, the way we think about management, at least from a surgical perspective, and how you're followed over the years and years following this. Your responsibilities and our responsibilities as your physician and a team. Thank you.